Like to call the Health Committee to order. Will the clerk please call the roll?
Representatives Alexander, Boyd, Byrd, Clemens, Freeman, Gant, Hakeem,
Here.
Hall,
Here.
Helton, Hicks, Jernigan, Kumar, Marsh, Mitchell, Ramsey, Sherrill, Smith, Vaughn, Whitson, Williams, Vice Chairman Leatherwood, Chairman Terry.
Here.
Mr. Chairman, you have a quorum.
Thank you. And before we get started, do any of the members have any personal orders? Okay, seeing none, I'd like to welcome everybody back to the Health Committee this year for 2022 session. We have a great staff working with us this year, and we have a few new faces, so I'd like to make a few introductions. We have Rajul Bayjoy, will be the committee attorney. We also have Zach Brown, the back, that will be our committee attorney. Harris King is our research analyst. Megan Dix be our committee assistant, and then we have two committee interns. We have Josh Say and Nick Jordan, and Josh is here, but Nick is a little bit under the weather, but he'll be joining us, I believe, next week. Today we do not have any bills on the calendar, but we do have a couple of presentations. We have DHS. They will be here to discuss the TANF Opportunity Act. And then later on, we will have the Department of Health, and they will be discussing the 10 Together opioid report that I guess came out in November, and give us a status update on COVID here in Tennessee. So with that, I'd like to bring DHS up to the table there and just make your introductions, and glad to have you.
Yes, that's it. Hello, hi, how is everybody? I will start off to say that I bought some really cool boots for such an occasion like this, and it says that the boots are waterproof. Yeah, so right after this, we're going right back to Macy's, because that is not the case with these wonderful boots that I have on right now. So hello, and I bring you all greetings from the Department of Human Services. My name is Sherelle Campbell Street. I serve as one of two deputies for Program and Services. I am joined today by the other deputy on the far left. That's Melissa Hooks, and she's over operations at the department. And then our wonderful Suzanne Carr, who is Senior Policy Advisor to the Commissioner's Office. So please do not adjust your eyelashes or your eyeglasses. Commissioner is not here today. He really wanted to, but unfortunately, he is not feeling well. So he really wanted us to make sure you know that he really wanted to be here, and he all wishes you health and wellness. We are so excited to come and present to you what I believe to be just a national model for the TANF program, the TANF Opportunity Act. And so we're going to just go ahead. We've got a few slides that we would like to just walk you through. And as we begin, I would like to also take this opportunity to also give a shout out to the wonderful 3,000 plus DHS employees who have been working tirelessly to ensure that our state's most needy people have their benefits during this precocious time in our society. So shout out to DHS. So TANF, everything that you want to know. In 1996, then the Clinton administration decided to redo one of the areas in the safety net, and that was the public assistance cash assistance program. TANF was born. It was designed first and foremost as or in his venue of this, he wanted to make sure, he being the president at that time and his leadership, wanted to ensure that we would not just give out cash benefits, but now really wanted to tie work to the program. So one of the first things that was really implemented as a part of TANF is the work components. You will see in back of me, there are several different safety net programs that have been funded and implemented by our federal government. May not be shocking to some of you, but believe it or not, a lot of them do the exact same thing. And they do it in such a way that has really compromised how we really serve our citizens here in our country. There are several different, I believe last count, there are 80 different programs that are departments that are designed to support the safety net. Next slide. Thank you, Suzanne. So one of the things, as I stated, that is lacking currently in our safety net environment is a lack of shared vision. Each one of the departments and programs, they all basically do the same thing, but they have little nuances in terms of eligibility and really, what are we trying to change? So what we know, and I have been working in state government for many years, what we know is that a lot of times in the federal realm, we measure things from a program standpoint and not necessarily from an individualized person standpoint. You should have just let me click, right? Yeah, okay. No, I don't want to. I'm scared of those things. To sum it all up, what we have before us right now, as in terms of on a federal level, is transactional interactions. We measure outputs and not necessarily outcomes. So that's really, when you talk or you know anything about Commissioner Carter, he really talks about shaking up the safety net on a national level. We believe that the TANF Opportunity Act is such a tree to be shaken, and we are really excited. I'm going to turn it over to Suzanne to kind of go into a little bit more about exactly what the TANF Opportunity Act is. Thank you for your support of it and why we believe that it will do the very thing that we hope it can do by bringing all of the safety net programs together. Suzanne?
Yeah, so sorry, forget to turn my mic on. So again, as Cheryl said, I'm Suzanne Carr. I'm the Senior Policy Advisor for the Office of the Commissioner at the Department of Human Services. And as Cheryl mentioned, Commissioner Carter, if he were here, he would probably pontificate for quite a bit longer than we are about the flaws in the safety net, but it's government centric, and that's what we have right now. And so our vision, using the TANF Opportunity Act that you guys passed for us last year, is to redesign this and think differently about how we offer these services to individuals. So what we want to do, and our vision, is to grow the capacity of these families who are in our safety net programs so that we can reduce their dependency on these programs. We believe that if families have the capacity to support themselves and are given what they need to achieve that they won't be as dependent on these services. And so we also want to redefine success. So as Cheryl said, currently what we measure are outputs. How many people did we serve? How many benefits did you get out? How many SNAP cases do we have? And that doesn't really tell you a measure of success on if a family has moved past their need for those services. So what we're doing with the TANF Opportunity Act and the Opportunity Pilots is looking at how do we measure those in outcomes? How do we know that a family that we served has achieved self-sufficiency? How do we know that they no longer need these services? And so to start on this journey of the TANF Opportunity Act, last year you guys passed that bill for us, and we are so appreciative. We started, soon after the bill was passed, engaging the different sectors of Tennessee, explaining this vision and getting input from them. We met with faith-based organizations. We've met with the business community. We've talked to philanthropic donors who also do this work in the private sector. We've engaged other state agencies. We've talked to our community action agencies and HRAs. And we've looked at academic and other non-governmental organizations and really tried to engage the whole of Tennessee in how do we tackle this problem. And so we believe that all of these services have existed in silos, and we need to use the TANF Opportunity Act to braid those together and work together to solve this problem. So just as a refresher, as I mentioned, you guys, this committee specifically was one of the first stops. Chairman Terry carried it for us, the TANF Opportunity Act. So it has several parts, and the key parts that we refer to specifically as the Opportunity Act pieces We are seeking a research partner to study these pilots. We've established an advisory board of 21 members that includes several commissioners, legislative membership, faith-based community membership, private entity, business community representatives, and Commissioner Carter is the chair of that group. And that group has started on the Opportunity Pilot Program process by awarding planning grants. After those planning grants, the board will then select those who receive the 6 opportunity pilots. DHS also gets to pick and manage one. And through that, we hope to see some of these changes. And we also, I'd like to make a plug, we have community grants that were established by the bill. Please let your communities know those are currently active for organizations to apply. That application cycle ends February 4th. So I will make sure that our team gets that in all of your inboxes, the link, but please let your organizations know for those who are not participating in the pilot program. And so, as I mentioned, we have that advisory board. If you'd like to tune in, those meetings are live streamed every third Tuesday of the month. Chairman Terry and Chairman Hawk, I know, would also be glad to let you guys know when those are happening, but that board is responsible for helping DHS select all of the planning grantees, select our research partner, and select the ultimate pilots that will be a part of this process. So to jump into where we are today as an update for you guys. So the legislation said that we could award up to $5 million to up to 50 planning grantees. The advisory board met in December. We had approximately 80 applications, and after mandatory review, which means looking through all of the federal requirements and did they meet the mandatory criteria, the board then evaluated 47 grantees. They selected 17 that are spread across the state. There are approximately 4 to 5 in each Grand Division and 3 statewide applications. We do touch all 95 counties with these planning grantees. So there is a statewide reach. The board ensured that every county would at least be touched in this planning grant process. And so the planning grant process is really there for these organizations to tell us what they're going to do. We're going to fund your ability to partner with other organizations and build out a very comprehensive plan to apply for one of the $25 million pilots. And these grantees have 3 months. This started December 30th was when their contract started. That'll be done March 30th, and the board will be in the process of evaluating during the month of March and also hearing in-person pitches from these organizations. And so just to give you an overview, because I know everyone wants to know who's serving in your areas. So in West Tennessee, we have 4: Agape Child and Family Services, Families Matter, West Tennessee Healthcare Foundation, and the University of Memphis. And their focus areas, I can tell you there are these broad topics, but we will have more detail when the organizations submit their actual proposal, which will be a much more detailed 30-page proposal at the end of March. In Middle Tennessee, we have Family Affair Ministries, Martha O'Brien Center, Goodwill Industries, Upper Cumberland Human Resource Agency, and Persevere. In East Tennessee, we have the City of Chattanooga, First Things First, Knoxville Community Development Corporation, United Way of Greater Knoxville, and the First Tennessee Development District. And then statewide, we had the Boys and Girls Club, the Tennessee Alliance for Legal Services, and East Tennessee Human Resource Agency. So these applications were pulled out of the by Grand Division because they are touching much more. And just as a reminder, the legislation said that the board had to select a minimum of 2 pilots in each Grand Division, or at least 2 pilots that are touching 2 in each of the Grand Division. So that's why we have split them out that way, to ensure for the board that when they pick the pilots, they have that statewide coverage. And so just as a reminder, DHS also gets to pick one per the legislation. And so we have chosen to focus ours on benefits cliffs. It will also be plucked out of the competitive process, but we have pretty publicly said that we want to select an organization that is doing that type of work. And so I will kick it over to our Deputy Commissioner, Melissa, to update you on the 2 RFPs we have associated with the TANF Opportunity Act.
All right, good afternoon, everyone. My name is Melissa Hux, Deputy Commissioner of Operations here with DHS. Just to give you 2 quick updates on 2 competitive procurements that are ongoing. We're only able to discuss a portion of that publicly, as they are out for bid as we speak. So the first one, as you see, is for a technical assistance partner. This will be a partner that will partner with DHS and with the pilots to share a suite of services to the grantees. This was put out for bid in December. We will be receiving proposals back by February 7th. So those are ongoing and active. We are working with the Central Procurement Office to ensure that we are supporting the questions and the responses from our vendors correctly. The goal is to have that announced and contract signed by mid-March, and it will go into effect June 1st. The second competitive RFP that is out is a researcher contractor. So this contractor will partner with us and with the pilots for scientific research, data analytics. We'll partner with our data analytics team internal to DHS as well. That went out for bid January 5th, and we are hoping to have that contract executed by the end of March with a start date of August 1st.
And so we would just steps and key dates so that you can continue to share them with your constituents who may be interested or organizations who are currently participating. So we've closed the planning grant application period. We're currently in the planning grant contract term. The next key step is for the board to receive those proposals and for them to complete their review. As I mentioned earlier, in the month of April, they'll do a review of the proposals and then also an in-person oral pitches. And so that will also be able to be live streamed on our website and for you guys to, anyone that's interested, to watch. They'll make their final selection in late April and we'll announce those May 1st. And then we'll have our research partner onboarded later in the summer. And so with that, if you're interested and have nothing going on at that Tuesday, February 15th, which I'm sure you guys are just not a lot happening on Tuesdays, our next advisory board meeting is that afternoon, and you can direct your nonprofit organizations and any other organizations eligible for TANF to visit our website and sign up and get email updates on grant opportunities and other things related to the TANF Opportunity Act. And so with that, Mr. Chairman, we are happy to answer any questions the committee might have.
All right, thank you. Representative Hakeem, you recognize?
Thank you, Mr. Chairman, Ms. Street, and ladies. Outstanding presentation, and we thank you for all the work that you're doing. In regards to the grants, and I'm asking a question. It's a 3-year pilot. Is that correct?
You recognize?
Yeah, so for the opportunity pilots that are selected, that is a 3-year pilot. For the community grants, those that are currently active and able to be applied for, those are 1 to 2 year smaller grants.
Okay.
So we have
But-
2 separate grant programs.
You recognize?
But the larger grant, is at 500,000?
You recognize?
It is 25 million over 3 years. So there will be 7 total pilots. Each will be funded at a max liability of 25 million over a 3-year period.
You recognize?
And if, I know we have researchers who are going to give us input at the end of the process. Is there, I may be asking too much, is a loan, say at the end of 6 months, a year, if there's a hiccup where services are not being delivered or something has gone amiss, are we going to know about it during that time, or is it going to be after the 3-year process?
You recognize?
Yeah, absolutely. Representative Hakeem, no, that research partner will be working with them in an ongoing basis, as well as that training and technical assistance partner. Both of those RFPs, those contract partners are intended to work with those pilots and ensure ongoing that technical assistance can be offered. And to your point, things can be altered and changed if we find out things aren't working. It's not meant to be a wait until 3 years have ended and find out none of this worked. It's not at all
And
intended to
if
be
I
like
could,
that.
Suzanne, if you don't mind. Also, we have staff who we have dedicated to this TANF Opportunity Act, who will also be monitoring on a monthly basis. They are charged with also making sure that everything is running smoothly. So we hope to have real-time information ongoing.
Just two
Yeah,
other
you're
brief
right.
questions. One, are we going to hold those persons who are observing on a monthly basis accountable? Who are we going to hold accountable for the hopeful success of this program or non-success?
So all 7 of these pilots will be under contract with the state. And so there will be terms in their contract that have, performance measurements and things like that, where the state can not only, withhold payment or enforce the terms of the contract to ensure that services are being provided.
Okay, one last question. The presentations today, will those be made available to us? And I think there was a link you also spoke of about grants and so forth.
I believe Harris has emailed everybody a copy of the slides.
Okay, all right. Thank you, Mr. Chairman.
Thank you. Representative Clemens, you're recognized.
Thank you, Mr. Chairman. A couple of questions, kind of in order in the way they were brought up. You used the phrase output versus outcomes, which sounds snappy and good, but is it the department's position that the amount and quality of output does not have a direct impact on the outcomes?
Thank you for the question. So what we mean when we say outputs, each program, the main programs, they measure how many people are receiving services. What we hope to change about that is to go deeper to find out, why did you need services in the first place, and how can we help improve your position or what's going on in your life so you don't have to come back. Federally speaking, what is being measured, we do not believe really impacts the generational poverty stance. And we really want to try to put these services in place so that future generations do not have to come to DHS. So that's kind of what we're talking about, not just measuring the number of people that we are serving, but how many families are we impacting.
Okay, and then the point was made that, and I'm paraphrasing here, if someone has the ability to provide for themselves, then they shouldn't be relying on these services. I mean, that was general, I think, the second person who spoke. So how do you gauge whether or not someone needs those services? Is everybody measured on the same plane? Because certain people have certain opportunities that others don't. Some people start out ahead of others, and if you're measuring them all with the same metrics, it's not necessarily equitable. So I'm curious as to how y'all gauge that, and if you could elaborate on it a little bit more.
Very nice.
Yeah, so what I meant by that was that we are looking to help address the factors that cause families to need our services and help move them to a place where then they don't. We definitely understand that people start in different places, come to us with issues needing our services. It's, to Sherelle's point, we don't want to just provide them the benefit and show them the door. We want to help address the factors that brought them to the door and then help them move forward to where they get to a place that they don't need our services.
And I think that's why am I on? No. And I think that's why this, our TANF Opportunity Act is so powerful, because to your point, the community will be telling us, based on the needs of the community, what are needed to gauge success. Right now, as you mentioned, if you show up and you're in the system, that is a measure of success, the number of people that we serve. So what these grants will help us to determine is the individuality of your need. And so we're really excited about that part. Both are needed, but one can really change the impact of how we serve Tennesseans more than the other.
One more.
Thanks, Mr. Chairman. Yeah, I appreciate you elaborating on that. I just don't want, and I'm concerned, in addition to that, about there being a checklist of you check this, this, and this. The same checklist applies to everybody. I'd like to hear what you said about the specific individual needs of each family. That's important to me. So I'll move, unless you want to elaborate a little bit further, I'll move on to the next question.
I was just going to say that part of the application process for the planning grants was to form collaboratives. So, multiple organizations in a community and give us a community-based solution, because we know what works in rural Tennessee is not the same as what works in Shelby County or Hamilton County. And so to Sherelle's point, we really wanted these to be community-driven proposals on how they would address the issues affecting their community. So absolutely, we don't intend for this at all to be a check, 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 all strictly uniform. We want it to be community-based and driven by the community and the individuals they're serving.
If let me interrupt and interject, that might help you. To your point, great questions. The meeting yesterday and the slides yesterday actually brought out some of that, and in your slide here about the benefits cliff, which I'm glad to see that you focusing on that. Part of it is some people start here before they get to the cliff. Some people are here. some people are here. And so you have to individualize that with them and determine their needs, what they're here, and they're at different points on that cliff. And then from an outcomes base, getting them past that cliff is what you're looking at. So you're recognized.
Thank you, Mr. Chairman. And also, I would just point out that, I mean, I know you were just using counties as an example, but there are different communities within counties as well. And I just want to make sure we're on the same page there. And then with regards to the contracts that are out for bid, and I understand that you can and cannot say certain things with regards to things from the bidding process, but what are the values of those respective, or what's the range of money that's going to be spent for the TA partner and the researcher?
You're recognized.
So at this time, we have not received any proposal, so we do not have a range of what's expected to come in. So once we receive those bids, then we will be able to match that up with the funding in the reserve to be able to support.
So the department doesn't have any set estimate that they're willing to pay a private company for those services, or what's that? I
We
guess
do have a loose budget, but I don't know that I'm able to discuss that publicly. It will give the vendors an idea of where to make their proposals.
Okay. And the makeup of the board that is the advisory board, that is non-legislative and non-departmental, what the private citizens who make up that board, who are they?
Of course, I don't think, sorry, Mr. Chairman. Yeah, I don't have that printed out. I'm absolutely happy to forward that to you. Or if you give me a minute and want to come back to me, Mr. Chairman, I can pull the list up on our website.
You can send it to me after the
Okay.
fact. Thank you. Thank you, Mr.
Absolutely.
Chairman.
All right, thank you. Representative Smith, you recognize?
Thank you, Mr. Chairman, and thank you all for what you've done. I do want to recognize the fact that Chairman Hawk and Chairman Watson in the Senate took the work from the working group appointed by both the speakers and worked with you all, and this has been the final product. So thank you for everyone for your leadership and making it an outcomes-based workforce development agency rather than a benefits agency. So thank you for that. One question I do have back to of course, I'm going to be very interested in East Tennessee, and I can't see I know we've got the slides, I just can't get them open. Could you go back to those three groups and kind of walk us through, how those were selected? I mean, because, back when we had the Tennessee Cares, I know that the United Way was selected, and I understand the criteria there. Was that a similar process on the choosing these? Again, not pitting anyone against the others, just wanting to understand. So because we're going to go back home and we're going to be asked, well, how did they get selected and we didn't?
So we did develop a evaluation rubric for the board, but I am going to punt a little bit to say that DHS did not select any of these. It was the board, 21-member board, evaluated all of them using the rubric, and then they held a meeting to deliberate and discuss and make the selection. So truly, it was the selection of the board. That I can tell you that they did ensure statewide coverage, equitable coverage, and ensuring that we had organizations doing different types of work. But again, I defer to Chairman Terry and Chairman Hawk to explain more on the thought process behind those selections.
Chairman Smith, I will say that from the rubric and all that, we at one point we were put in different groups, I guess 7 of us per group or something along those lines, and assigned certain of the proposals to evaluate. And then I will tell you that I was surprised. We got those back really quick, and it was very thorough. And when I looked at them, I know that the way that I graded it, I had a spreadsheet and all this for it, but it was very thorough, I think, from the process. And then there was a meeting for discussion. They narrowed those down. But Representative Smith, you're recognized.
All I want to say is thank you.
Representative Mitchell, you're recognized.
Yeah, thank you, Mr. Chairman. So back to these groups that were selected. No, you didn't pick them, but did the department do any kind of background check? See if they're really legitimate organizations or if there's anything questionable?
You're recognized.
Yes. So yes, Representative Mitchell, our Office of Inspector General went through the entire list of applicants and ensured they were cleared to do business both with the state and with the federal government. Our program team also went through and did a check of what they were proposing to ensure that it, at a baseline, met the requirements of TANF and could be something funded with TANF. And so, as I mentioned earlier, we had 80 applicants, but going through all of those processes, we weeded out and only passed along 47 to the board. So we did do those mandatory checks. And if you didn't meet those boxes, you didn't even make it to the board to be evaluated.
You recognize?
So how much money will each one of these applicants receive?
So I can provide that. We had up to 5 million. These organizations submitted their budget, so they were funded at the amount they requested. The highest funded organizations were cut a little because they requested more than we could fund, but it's varying amounts. I'm happy to provide that. I don't have it in front of me.
Yeah, please. And if you could also give me what they requested as well, because I'd like to see on a couple.
Mhm.
Thanks.
Thank you. Any further questions? Okay. See no further questions. Thank you guys for coming up and presenting today. And if you have any further questions for the committee, just email them and they'll be more happy to get you what you need. So thank you. Appreciate it.
Thank you, Mr. Chairman.
Okay. And with that, we will like to invite up Commissioner Piercy and Department of Health. Did you guys want to start off with opioid or?
Mr. Chairman, I hope we understood the assignment. I've got a pretty substantive COVID update and
Okay.
then a few slides on TN together.
Okay, which would you like
That-
to do first?
Well, the COVID's up first.
Okay, let's do that.
Mr. Chairman, thank you for having me today. I'm Lisa Piercy with the Department of Health. To my right is Dr. Morgan McDonald, who's our Deputy Commissioner. But the most special person in the room is Beth Maples, who will indicate herself by waving. Beth is in town today because she is our Department of Health Governor's Excellence in Service Award recipient. She came in for lunch today. She is the office supervisor at our Sevier County Health Department and has been with us for 15 years. So she is representing the entire department today, and we're glad to have her. And I
Thank you.
invited her
Thank
to
you.
sit at the table, but
Congratulations.
she declined. Thank you. Thank you, committee. Glad to be here with you today. Can you be my? Thank you. So wanted to provide you with a pretty substantive update today because I know you guys are getting lots of questions. And you may have questions yourselves that haven't been answered publicly. So I wanted to give you an opportunity to do that. So I know you're familiar with this curve. This is what we call our epi curve. The thing you will notice here is that this most recent surge all the way to the right of the screen is right now. It is an order of magnitude higher than the highest surge before, maybe 1.5 times the previous high. So let me also give you some good news. I think I can reach it. Oh, look at there. Thanks. We're starting to plateau and starting to drop off in our metro areas. So that is a good sign. Our rural areas aren't quite there yet, but historically speaking, when we've seen these patterns with case trends, the rural areas generally follow a week or two, sometimes 3 weeks later. But essentially, all of our metro areas are now in a plateau or in a downslope. So that's a good thing. The reason, when you go back to looking at the magnitude of the current spike compared to others, is because of the very, very high transmissibility or contagiousness, if you will, of the Omicron variant. The Omicron variant nationally now accounts for about 98% of all infections. So we don't have any reason to believe it's not close to that here. Maybe a little less than that here, but still certainly upwards of 90%. So the vast majority is Omicron. Keep that in mind because that's going to come into play in just a minute with some of my other comments. The other thing that I want you to keep in mind when you look at a graph like this is even as high as this spike is, it's a significant underestimate of what the actual disease burden is for a couple of reasons. One, because there is some level of both natural and acquired immunity in our population. We think that we know that there are a lot of asymptomatic people walking around. So those would not be reflected in this number because generally If people are feeling well, they don't test unless there's some reason for them to do so. Likewise, a reason that, and it's a growing reason that this is an underestimate, is home testing. And so home testing, even since the surge in the summer, has really taken off. Now, it's still difficult to find commercially at times, but we have exponentially more home tests now than we did just 3 or 4 months ago. And then, as you know, our federal government partners soft launched and yesterday, and then hard launched today, the covidtest.gov website, where each household can receive 4 at-home tests per address. If you haven't done that yet, I encourage you to do that. It's super easy. I was able to do it on my mobile device in literally just 2 or 3 clicks. So it's a really good thing to have on hand at home, particularly as we go into the future months. If you're sick, you can test at home. So now let's talk about hospitalizations, because this is something that's also shifted from the last surge, or all of the surges before now and versus now. So when you first look at this curve, so overall on the far right, you will see that the hospitalization number almost approximates that of the highest peak that we had back in the summertime surge, and is about equal to that of last winter's surge. And I'm going to tell you that there is a big asterisk by that, because it is not necessarily an apples to apples comparison. In the past, hospitalization numbers have essentially been used as a proxy for virulence. So what that means is, if hospital numbers go up in relation to case numbers, it can mean, oh, this strain is making people really, really sick, and they're going to be in the hospital more often. That's what happened in July and August with the bad Delta wave. This one is a good bit different because, and you've probably read about it nationally, of what we call incidental findings. So before I talk about that, I want to make clear there are some really sick people in the hospital with COVID. I do not want to diminish that at all. And a majority of people that are in the hospital with COVID are there because of COVID, and they're very sick and should be taken very seriously. Largely still unchanged. Those are unvaccinated folks for the most part. What is different is that, nationally speaking, about 30 to 50% of hospitalizations with COVID right now are what we call incidental findings, which means they're there for some other reason and they happen to have a positive COVID test. So, we heard lots of rumors about that early on of, oh, you're counting it as COVID if, they're in for a car wreck or whatever. That didn't happen very often in the past. If you were one of these previous spikes and you were in the hospital for COVID, it's because you were sick from COVID. But now, because Omicron is so contagious, there are a lot of people in the hospital for something else, and by the way, also have COVID. Now that matters, and it sort of doesn't matter for a couple of reasons, and let me tell you about that. Incidental findings really are measured by, or are reflective of, the screening procedures at the hospital. So some hospitals don't test you unless you come in with symptoms for that process. There are other hospitals that test every person that walks through the door. And so you might be there with chest pain or GI bleed, but if you're positive for COVID, you're marked as that. And then everywhere in the middle. So some of them just do it for pre-op, some do it, all different kinds of ways. So it's I'm oftentimes asked the question, well, why don't you guys report the number of true, I'll call them true, versus incidental findings, or symptomatic versus incidental findings? And it's because there is no standard screening policy. Individual facilities will likely have that information, and what we have heard from the facilities that measure that here in Tennessee is pretty consistent with the national average. So between 30 and 50% of hospitalizations are there for something else. The other way that you can tell that is when you look at the ICU curves. And if you can see on the bottom, those bottom 2 curves are ICU and mechanical ventilation curves. In proportion to the overall cases, they're relatively quite small. So this is another way that we can change. So I wanted to cover that to explain why this looks the way it does. At the end of the day, hospitals really, it doesn't change what they do if you're positive if you're there for COVID or if you're there for some other reason, it takes the same amount of PPE. It takes the same type of isolation. It takes the same type of special precautions. And so from a hospital standpoint, it really doesn't matter. But I just wanted you to be aware that this no longer is a proxy for virulence. And people, it might not be quite as bad as it looks on the screen. Let me tell you the other part of hospitalization that is a little bit different, or hospital situation than it was. We are having significant problems with staffing hospitals right now. And it's because, just like every other industry, employees are getting sick. And, they have to be out for 5 days or 10 days or whatever, the guidelines that apply to them are. And so we've got hospitals and health systems across the state that have 500, 700, 800 employees out at any one given time. That creates significant strain on any business to have 8 or 10 or 15% of your workforce out. So I just want to tune you to the fact that if you're reading reports that, oh my gosh, this is higher than it's ever been and this is worse than it's ever been, you need to take it with that grain of salt. I do not in any shape, form, or fashion want to diminish what is actually happening, because there are bad things that are happening out there, but it's not the same as it was in the summer or last winter. That's probably enough on that. I'm happy to answer more questions if you have them in a minute. Here's the other thing that I bet you're getting a bunch of questions about, and the thing that has probably seen the most movement in the last 30 days or so. And it's a broad category that we call therapeutics. And that's basically everything that you can do after you already have the infection to get better. So I've split them out into sort of 2 big categories here: antivirals and monoclonal antibodies. But there are different little nuances of those. So on the antivirals, there is an IV antiviral called remdesivir. That one's been out since November of 2020. It is now, and I think has been for almost a year now, commercially available. That, thankfully, is the only thing, not thankfully the only thing, but thankfully that one is commercially available. We don't have to allocate that from a state standpoint. We don't have to order it. That is available on the commercial market. Hospitals do that directly. You probably haven't even heard the term remdesivir in several months because it's pretty readily available and hospitals can get it. That is what you get once you're already in the hospital from an IV standpoint. The newer therapeutic are the oral antivirals, and I'm sure each one of you is familiar with Tamiflu, which is the brand name of the oral antiviral used for influenza. So over the last 4 to 6 weeks or so, there have been 2 oral antivirals come out, one from Merck called Molnupiravir and the other one from Pfizer with the brand name Paxlovid. So much like Tamiflu, these are pills that you take shortly after diagnosis, preferably in the first 3 to 5 days after symptom onset, and you take a whole bunch of pills for about 5 days. And it does have significant reduction in both symptoms and progression to severe disease. The Pfizer product, the Paxlovid, appears to be much more effective than the Molnupiravir, with about a 90% reduction of progression of severe disease versus about 30%. So, and I've got a number slide coming up next, so just hold that in your head. But these are products that are being allocated directly from the federal government, where we have to direct where they're going to. So if this sounds familiar to you, you'll remember that's what happened when we had very small quantities of vaccine at first. So we had to say, okay, the feds give it to the state, and the state says, or they ask the state, where do you want this to go? And so we have to pick someplace that can geographically cover pretty much the whole state, at least within a certain distance. We have to be mindful that it is accessible to all patients. So not give it to a certain entity that excludes some other type of patient type or whatever. We have to be mindful, or we want to be mindful, of what we call the Social Vulnerability Index, which means equitable access for those most vulnerable populations. And just like vaccine, we when we looked at the map and looked at the geography, the Walmart retail chain checked those boxes. It had a bigger or a wider penetration throughout the state, particularly in rural areas, more so than Walgreens, CVS, Kroger, Publix. We looked at all of them, and then certainly any of the independent pharmacies. Now, also, just like vaccine, as soon as we get more, we're going to start making those concentric circles wider and broadening that distribution network. So I know there was some questions early on of, well, how'd you end up picking Walmart? And it had to do with geographic distribution and equitable access across the state. So those oral antivirals are being allocated to us on a bi-weekly basis, and I'll show you the projections in just a second. The other two therapeutics, one you're familiar with, one you may not be. The one you may not be familiar with, and this is a mouthful, it's called a pre-exposure prophylaxis monoclonal antibody, which is maybe something that you'd never put those terms together. So everybody's pretty familiar with what a monoclonal antibody is. That's the IV infusion that after you test positive, if you get within 10 days, it significantly reduces your chances and is wonder drug, significantly reduce your chances of going in the hospital. They now have a product that you can get before you get infected that will protect you for about 6 months. And if that sounds like a vaccine substitute, you're not far off. And it's not a vaccine substitute, but it is for patients who are expected not to respond to a vaccine. So patients who are severely immunocompromised, transplant patients, patients on chemo, patients with severe suppressive disorders and immunodeficiencies, you can give them a vaccine all day long and they won't mount a response. But they will be offered about 6 months of protection if you give them one of these IV infusions of this combination monoclonal antibody product, it's brand name Evusheld, about once every 6 months. So we've also been getting those. I bet that one's flown under your radar because that one is a pretty unique product for special populations. We have sent that product to 8 of our major medical centers around the state. It's also in very limited supply. And again, we will expand that out when supply allows. But in those 8 major medical centers, which are listed on our website, people who have those kind of conditions are likely being treated at those larger medical centers anyway. So if you or your family or your constituents fall into one of those special categories, and their doctor, their oncologist, their transplant surgeon hasn't reached out and said, hey, you really need this, you need to be reaching out to the doctor and say, I can't take a vaccine because of my immunocompromised state. Can I get this Evusheld infusion? So that's one you may not have heard of. But the one that everybody's heard of is just the standard post-exposure monoclonal antibody. And that's the infusion that you get after you're positive. Well, for months, over a year now, we've had 2 kind of standard monoclonal antibodies. One is Regeneron and one is a combination product that we shorten to BAM-EDI. And really haven't had any supply issues with those in quite some time. We did early on, but they got resolved pretty quickly. And so we were perking along all through the fall and coming into December, and then it kind of hit a screeching halt because we realized that the Omicron variant is resistant to those 2 monoclonal antibodies. So it essentially took them out of our toolbox. We've got plenty of those, but I told you earlier, the penetration of this variant is 98% nationally and probably close to that here. So all you're doing by giving a patient one of those, unless you know for a fact that it's not Omicron, is essentially wasting time where they could be having a more effective treatment. So that gets us down to one monoclonal antibody product that is that works against Omicron. This is a product called Sotrovimab, which is manufactured by GlaxoSmithKline or GSK. And this was one that was not initially procured by the feds and allocated to the states. It was just on the open market. That created a lot of demand. And so there was sort of a shortage scenario even before we knew about the Omicron resistance. Well, then when we as a nation figured out that Omicron or Sotrovimab was the only one that we could use, then the Fed said, okay, we're going to buy all of this and we're going to distribute it to states. There just wasn't that much to buy. Unfortunately, since probably the week before Christmas, we've only been getting between 600 and 800 doses a week for the entire state. That does not go very far. When we had sites that were sometimes infusing up to 100 patients per day at one site. So we're talking about a max of 800 doses for the entire state. So your constituents very likely can't find monoclonal antibody. That's essentially the same everywhere in the nation right now. So here is the projections that our federal partners sent us for the month of January. I was a little disappointed. Frankly, I was a lot disappointed when I saw this because in, I guess, the week of Christmas or the week after Christmas, we were promised that we would see a big bump, like almost a 6x multiple in sotrovimab, either the week of January 3rd or January 10th. As you can see, that didn't pan out. The sotrovimab line is the fourth one down right there in the middle. And so you can see there are only 52,000 doses nationally. And these are being allocated out based on population and disease burden. And those numbers are published every week. I think this week we got 720 doses. Last week we got 600 and something. So unfortunately, I don't expect an increase in that for the foreseeable future. Hopefully February will bring better news. But that is our projected allocation through the end of the month. You can see we've got plenty of Regeneron and BAM-EDI, but I've already told you that's kind of a moot point. And then you can see that the oral antivirals are being allocated on a biweekly basis. So again, we don't have any eyes on when we might get more of those. So it's kind of bad news, but I wanted to give you the full detail of the state is ordering everything made available to us. It's just there's just very little to be had. The good news is we've got plenty of vaccine, and vaccine is still the most effective way you can prevent disease and particularly progression to severe disease. To orient you a little bit to this slide, the orange bars on the right side are the proportion of booster shots of all of the vaccines being given. So we have had some pretty decent uptake of boosters over the last several weeks. And then my last slide on COVID is just to remind you of booster eligibility. The bottom line is essentially everybody age 12 and up is eligible for a booster 5 months after an mRNA, which is Pfizer or Moderna, or 2 months after a J&J. All right, a few slides on Tennessee Together, which totally shifting gears to, we all like to talk about non-COVID things. So this is something that Chairman and others spearheaded in 2018. Is that right, Chairman? 2017, 18. We'll go with that. Oh, there it is right there. Enacted in July of 18. So it would have been prior to that, which reduces the number and amount of opioids, short-term opioids that are prescribed. We were talking about this over at the office this morning. I'm sure each of you can recall a time in the distant past, hopefully very distant past, where you would have a routine procedure, a tooth pulled, a minor, some kind of minor procedure, and you might be given 30 or 40 or 60 hydrocodone tablets. And what we learned over time, we as a medical industry, and it was quite shocking, is that for opioid naive patients, so that means patients who aren't used to taking opioids and are very sensitive to that, it might only take 5 or 7, certainly no more than 10 days to become physiologically addicted to prescription opioids after a perfectly normal procedure. And so it was really important work to be able to shorten the duration of those acute, we'll call those acute versus chronic pain prescriptions. So what it did was this placed a limit on how many days you could write that prescription for and what your morphine milligram equivalents are, basically how strong of a drug you could write. And it didn't get in the middle of doctors making their own judgments, and it didn't have anything to do with chronic pain patients who relied upon these on an ongoing basis. But I think this is a very illustrative graph that shows you the impact of that. So in case you can't see the labels there, that first or that top line shows you the overall decline in opioid prescribing. Now, you will note the shaded part on the right side is since the legislation was enacted. It was going down before that, but the legislation continued that acceleration. So there were or I should say, there were less patients receiving prescriptions for opioids, and when they did, they were shorter in duration. So that's what you see, the 3 lines on the bottom is the duration. You've got the categories of 1 to 3 days, 4 to 10 days, and then 10 plus days. And that line that starts out in the middle and then crosses up and over once the legislation takes effect in the shaded area is you will see that the proportion of prescriptions written for a duration of 1 to 3 days went up, and the proportion of prescriptions that were 4 to 10 days in duration went down. And that's what I want you to remember, that 5 to 7 or 5 to 10 days is the magic number where people who are opioid naive can tip the scales into becoming physiologically addicted. And so this is a graph of those opioid naive patients. Again, on the right side is the shaded portion where the legislation was impacted. You can see that the number of opioid naive patients that became dependent on these went from 4% to 3%. That might sound insignificant, but those are hundreds, if not thousands, of families that were spared from addiction and patients and their families because of that. And then finally, as I mentioned a minute ago, this did not impact chronic pain patients. Chronic pain patients who rely on that on an ongoing basis and are under appropriate care for chronic opioids were still able to do that and didn't see any significant change. Chairman, I hope that answered your questions.
Thank you. I'm going to take in a list of people that have questions, but I do want to, can you go back to your COVID-19 hospitalization slide there? And I just want to give some people a kind of a real world example. Obviously I work in a hospital and I track these things with our hospital as well. And during the second peak there, our hospital's, I think, 358 beds. The second peak, we got up to 147 of patients were COVID patients. And the bottom line, the ICU, 39 of the 42 critical care patients we had were COVID patients. In our ICU, they're ventilated or struggling in some form or fashion or long-term ventilator. As that peak went down, we got down, I think the lowest number we got was 23 patients total in our hospital, and we got down, I believe, 1 or 2 patients in the unit. And that has since gone up, and I think we've gotten up to around this past week or so in the 90s in our hospital. And it's, like you said, it's kind of plateaued, at least this week, knock on wood. And our hospitalizations or ICU hospitalizations got up to around 16, 17, and that's, knock on wood again, right at that. So from a virulence standpoint, tracking the ICU, I think that's something from a real world, you can see that here. And I just wanted to let people know that I see that, I've tracked that. This is something when I see it, I've obviously called Dr. McDonald and you a lot on this, so appreciate your help. But so with that, I've got some members on the list. Leader Gant.
Thank you, Chairman. Commissioner, thank you for being here and all the good work that you and your team are doing. When somebody tests positive for COVID, how long can that, if they're tested for 90 days, can they still show that they're positive even after they've left many symptoms behind and still test positive up to 90 days? And are they at what point contagious or not contagious? Can you expand on that?
Sure, that's a great question, Leader Gant. And the answer is it depends. it depends on a lot of things. So first and foremost, it depends on what kind of test you're doing. So a PCR test will remain positive for a much longer time than a rapid antigen test. Rapid antigen test is what you have at home. That's a quick one. The PCR is sort of the old school, kind of the first one we had, that goes pretty far up your nose and is run through a traditional lab. PCR test generally will stay positive from anywhere 2 to 5 weeks in a normal scenario. There are some people that can keep a positive PCR test for 7, 8, 9+ weeks. Now, as you mentioned, that does not necessarily, or it absolutely does not mean that they are infectious for that long. We know that except in very rare circumstances, most people are infectious for about the same amount of time, 5 to 10 days. And after about the 5th day, the viral load, or how infectious you are, drops off pretty precipitously. I think you'll see that was some of the science behind the recent CDC change in isolation. On the rapid antigen tests are a better indicator of infectiousness or how contagious you are to others. Now, we get a lot of questions about, if I still have a positive test on a rapid antigen, am I still contagious on the 10th day, 11th day? Probably not. But generally speaking, if you're still positive on a home test, you may very well still be infectious.
Okay, thank you. Now, I want to shift gears a little bit, and you were talking about the drugs to treat COVID. Are these drugs approved by FDA under the same emergency order as the COVID vaccines?
That's right. For the oral antivirals, those are now available or approved under an EUA. Remdesivir already has full approval, the IV form. And so over certain period of time, months usually, that EUA does convert to a full approval. I believe the first round of vaccines have that now. And maybe maybe Regeneron, one of the older monoclonal antibodies. But the new oral antivirals, the 2 that I mentioned, those are still under EUA.
Thank you. Now, when a doctor is consulting with their patient over a COVID illness, how do what steers them to one drug over another drug with their patient? I mean, help me understand what that's like.
To be honest, most of the time is what's available and what's available nearby. The oral antivirals are effective in reducing progression to severe disease. I did mention that one is more effective than the other. And we leave that all up to the clinical judgment of the provider. So the more high-risk individuals, the elderly, those with immunocompromising conditions, people with things like obesity, hypertension, diabetes, the things that we know make you at higher risk for severe disease, those are the ones that should be, in physician's judgment, the ones that are directed to that treatment.
So we really don't know if there's any long-term side effects to these drugs as doctors prescribe to them, right?
So the oral antivirals, these particular ones are relatively new. The concept of oral antivirals is not new. And in fact, the Paxlovid is a combination product. And one of those products is a drug that's been used to treat other viruses in the past. And that one, I think it's been around quite some time. So there may be some more long-term data on that one.
Okay. Is ivermectin ever mentioned?
Later, Gant.
Well,
actually,
let me just say
yeah.
this. I'm trying to put to bed some of the stuff that we hear from our constituents. Either there's truth to it or there's not truth to it. I just want to know, and I think
No,
it's fair to
it's a
everybody
fair
to know
question.
what-
Sure.
yeah.
Sure, it's a fair question. To be honest, we heard a lot about that in the summertime with the Delta surge. Haven't heard much about it recently. For me, the most important part as a physician, a state health official, is I haven't heard any robust science behind it, nor have I seen any official recommendations or approvals of it. And so I don't know if that's coming in the future or not. But right now, while it's not, we don't recommend it.
Okay. All right. That's all I had. Thank you. I didn't mean to put you on the spot. I just had a question.
I'm used to it.
Thank you.
Thank you. Representative Byrd?
Thank you. I was wanting to put something else to rest too. I've heard for so long now that hospitals, they get an extra 20% if it's a COVID patient. Is that true?
I'm so glad you asked that, Representative Burden. I'm so glad to see you in person too.
It's good to be seen.
Yeah, I bet. No, sir, that is a common rumor or myth that we hear, is that hospitals get paid more for COVID patients, or that they get paid more if there's a COVID death or whatever. That's not true. What is true is that with any condition, so as you know, when people go into the hospital, they very rarely just have one thing wrong with them. So they're there and they have pneumonia, but maybe their diabetes is also out of control. And maybe they also have the flu. There is a provision, like with any other condition, for a hospital to add what's called a modifier, because hospitals are actually, and my healthcare counterparts in the room, particularly the hospital-based one, know that hospitals can be penalized if their length of stay, or financially penalized if their length of stay exceeds what that condition is supposed to have. So for example, if the insurance company says, well, you've had a heart attack, we'll pay you for 3 days, that's different than if you have a heart attack with COVID, with diabetes, with something else. And so those are modifiers that do allow for a higher acuity and more resource coverage, but there is no differential or bonus or anything like that that hospitals get for COVID patients. It's
Okay,
just
thank
a
you.
longstanding rumor.
Thank you. And another question is, are the Department of Health in the county, are they posting a daily on the COVID numbers?
I'm glad you asked that one too. So when we talked about that very first curve, and as high as that last surge is, that is such a significant underestimate of what the actual disease burden is. Because these numbers are less and less accurate with each passing week, our daily case numbers are less and less useful. So what we do find useful are trends over time. And we're starting to see the move away from daily numbers spread all over the nation. I can't remember the exact number. Last time I heard it was 20-something states are no longer reporting daily. The Associated Press has asked their reporters to stop reporting daily case counts because they're inaccurate. And you may have seen in your NCSL newsletter on Monday, that was the lead article about the declining usefulness of daily reporting. So we now report weekly. That doesn't mean that we're not watching things like hospitalizations and deaths on a daily basis, but we're reporting publicly weekly now. The other reason, frankly, is that it's pretty clear we're not going to get over this anytime soon. We're going to be dealing with this for a while, and we have got to normalize this into typical operations. And so we are making it like every other condition that we report. We report flu weekly. We report other infectious diseases that way. And so we are normalizing this into our daily operation.
Okay, and one more question. I know Walmart has the agreement that they'll be the only ones right now on the new oral medicine. How long do you think that the regular independent pharmacies are going to get that?
Well, I would have hoped it would have been this week, but with those projections, it looks like that our allocation, and that's the top 2 lines, we get those bi-weekly allocations. So we got one last week. We'll get another one next week. It will be at least the week of February 7th before I could potentially see an increase. And as soon as I see an increase, we've already got it mapped out to where what is the next layer and then what is the next layer. And so just like we did with vaccine, when we get out to where we're ready to send it to independent pharmacies, we'll put out a call and say, hey, if you want this, register in the portal, and then we'll do it just like we did the vaccine.
Well, I know that, like in my case, I'm taking so many medications, different medications. I'd hate to go to Walmart to get that and then not knowing my condition or what other kind of medications I'm taking. So it just kind of wears me on people like in my situation.
Yes, sir. And actually, that's a good point that I didn't mention. There are a couple of provisions that physicians have to keep in mind with these oral antivirals. They're not, I can't remember which one, but at least one, if not both, cannot be used in pregnancy or lactation. And then one of them does have some significant drug-drug interactions. And so have to have a lot of cognizance of those risks when prescribing these drugs.
Okay, thank you.
Thank you. Before I get to the next person, I just wanted to follow up on one of your comments about modifiers and costs. And I don't think a lot of people know that, like, if there's like a COVID ward, or at least, over the summer when they had those, and it's not apples to apples, people going into the hospital and you get paid for this hospitalization versus this hospitalization. For COVID patients, the cost increase for PPE, and additionally, you may have to pay, shortages of nurses, staff being out for COVID, whatever, but, you may have to give bonuses to those nurses that may want to, to work on that. You had to incentivize them. And so the costs go up for that. So having modifiers for the hospital, at least to break even or cover those costs are part of that. And that's something not just for this, but in anesthesia, we have modifiers. Sicker patients are, the more we have to do it in ICUs. When we talk about that, when patients are in the ICUs, oftentimes their IVs, normally you have your IV hanging at bedside and it's right there next to them. COVID patients, the tubing goes out the door oftentimes and it's outside, and you're changing the bags outside, so you don't have to go in and out and potentially spread COVID. And so there's more cost to that. They're wearing the different masks that they have. So just keep that in mind when you talk about costs. Representative Smith, you recognize.
Thank you, Mr. Chairman. If you would indulge me for a couple of questions. Thank you, Dr. Piercy and team. I don't want to misrepresent your words, and just for a point of clarity, you had mentioned on the hospitalizations that, and let's see if I phrase this correctly, that the latest data does not reflect hospitalizations based on a primary diagnosis for admittance for COVID. Rather, they're there for another primary diagnosis, and while they're there, they're testing positive. Would that be a fair assumption? I'd like for just a little bit of clarity. if I would.
Sure. Thank you for asking for that clarity, because it is a bit of a nuanced discussion. And the answer is it's both. So this number of hospitalizations, these represent patients in the hospital with COVID. It does not differentiate if they were admitted because of COVID or with COVID. Because it is so prevalent in the community right now, it would be really common for somebody who's there with some other condition to have COVID. But it's also prevalent in the community right now, and particularly amongst unvaccinated people. So it's more common for people with COVID to be admitted. So I may have confused you more, but it's both, ma'am.
Thank you, Mr. Chairman, and thank you for the clarity, because I think the safest way to say is there's no distinction for the primary diagnosis. If you would, just for a moment of public service, could you speak to the definition of endemic? We're hearing that in the reporting that we're now seeing COVID at endemic levels, and I take that to be a good thing, and some people react to that. But would you offer your professional opinion on what endemic means to the public so we can watch this back home?
I will be glad to try. I wish I had an epidemiologist with me, because there is an official definition of that. But generally speaking, it has to do with scale and how many people are being infected and how widespread it is. So right now it is at a pandemic level. You will remember 100 years ago, y'all don't remember, nobody in this room remembers, but you will remember historically that 100 years ago, flu was a pandemic. And over time, over time, as the population's immunity builds, both in our situation now, both naturally through infection and acquired through vaccine, it becomes less and less of a disease burden over time. And so there is an official definition of when it shifts. That's the part that an epidemiologist would have to tell you. But over time, it will become one of these things that we just live with. Flu is now endemic. It's hard to imagine that 100 years ago, they were feeling the same way about flu as we feel about COVID now. And now you know how we feel about flu. It's like, well, it's dangerous to some people, but it's always there, and we're going to take, the mitigation measures that we can, but we're going to go ahead and live our normal lives. And so that is what we are quickly getting to with this. There's a lot of speculation that this will be sort of our last bad surge until we transition into that. I will say that there is no magic number. There is no magic date that was, okay, if you get this, then it's, it's going to flip the switch. But we are moving very quickly towards that point.
And thank you, Mr. Chairman. One final question. I'm sorry to monopolize the time, but looking at the slide on the projected therapeutics and the allocation, in your professional opinion and compared to our other states, do you believe, and again, if you don't feel comfortable answering this question, I don't want to put you on the spot, but do you believe that the state of Tennessee is receiving its fair share of allocation of all of these critical therapeutics? And do you believe that there's any sort of, I don't want to call it punishment, but clearly, retribution, something like that? Do you believe in your estimation that CMS has been fairly allocating these resources based on need and population of states or cases as opposed to some other metric? Thank you, Mr. Chairman.
It's a legitimate question, and I'm glad you asked. And I want you to know that I watch that very, very closely, because if there's any indication that we're not getting our fair share, I'll be calling that same day. And to our federal partners' credit, they are being very transparent about what every state gets. And so I can see the breakdown of all of these products for every state. And whereas they don't produce the exact algorithm of how they come up with the calculations, they do generally tie it to both population and disease burden. And when you look at the allocations and how they change week over week, you can see that regardless of whether the state is red or blue, you are starting to see more go to states that have a higher disease burden and vice versa. And so the short answer to your question is no, I haven't identified that, but I'm keeping a close eye.
Thank you, Representative Clemens. You're recognized.
Thank you, Mr. Chairman. Commissioner, what's the total number of COVID-related deaths in Tennessee as of today?
That is a good question. I will look at, it's just north of 20,000. We had 18 and a half or so right before Christmas. And then we had the data dump that we had, which put us just over 20 or 21,000.
So we've had 2,000 about in the last month?
Oh, no, sir. That was a long explanation that we went through in December. I'm happy to send you the media briefing I did on December 22nd. It has a very long explanation of the data lag and the 2,700 deaths that were identified through the Delta surge that were added in late December. But those were from dates of death in July and August.
Okay. I seem to recall that now. Where do we rank nationally in COVID-related deaths per capita?
Last time I looked, we ranked about the same as everywhere in our other metrics, depending on how you do it, low 40s, so 42, 41. This last week, the White House report that came out yesterday, I think we were 42.
So 42 worst or best?
Worst, along with all of the rest of the our southern state counterparts.
Why do you think that is? You kind of say that as a given. Why do you think that is?
Oh, yeah, I do consider that a given. That is where the vaccination rates are the lowest.
Okay. And so you think those vaccination rates are direct correlation to the death rate?
I think there is a direct correlation between vaccination rate and death rate, or lack thereof.
Yeah. So I think last time you were here, you were generous enough to answer this question. So now with the benefit of multiple peaks behind us, multiple variants, almost 2 years of this pandemic behind us and more ahead, unfortunately, what is the department or the administration doing differently now than you were doing early on? And looking forward, what would you do differently? I mean, what have we learned from this, and how has it benefited you, and what practices have you put in place to help our society and state better respond to these pandemics?
Sure. That's a very large question. I'll try to unpack a little bit of it. In some instances, this answer may surprise you. In some instances, I'm not sure a whole lot has changed. That is not to say we haven't learned things or we're not doing things better than we used to. But the same things that we knew worked a year ago work today. And there's really not a whole lot new under the sun. When you're sick, stay at home, wash your hands, get a vaccine. These are not new things, which is compared to yesterday or tomorrow if the case count is up or down 200, because the same mitigation measures are the same. I think what we've learned throughout is that physical health is not the single important thing. Economic health, mental health, health and welfare of children and safety of children, there are a lot of things to consider other than physical health. And I think that's something that we've been able to improve over time, and certainly not unique to Tennessee. Across the nation, I think people are seeing that, yeah, we can protect health. And I don't know if you're keeping up with what's happening in, I can't pronounce the name of the province in China where they are trying to shoot for zero COVID and locking everybody down. There are some very serious and lifelong consequences that come with that. And we certainly were never to that here or anywhere in this nation, but it has illustrated the point of we have to take care of the whole person, and we can't make risk zero. And when you try to make a risk zero, then it's just squeezing the balloon. It pops up somewhere else. And we're seeing that right now. And Dr. McDonald could talk for an hour about the mental health crisis we're seeing in children and in adults, and the drug overdoses and all of the things that we're seeing. So I think if we've learned anything throughout, we as a nation, as a society, have learned that, yes, this is a serious physical health threat, but it's not the only thing that matters.
Yeah, I appreciate that. And I'm glad you said the mental health. I mean, I'm a big advocate for mental health parity. And I think that we're still battling that front in this state. And I think our state can do a lot better. I won't go on that rant, Mr. Chairman, but that's for another day. But you raise an interesting point about children and their mental health. I've got 3 small children. I watched what happened with different age groups because I've got 3 different ages, and the impact that it had on them. And I made the point last year in a different committee, I happen to serve on the education committee as well, that we're going to see this for years.
Yep.
And we've got to address that. I mean, we're going to see the impact of on those children and our students in the schools for years. And, you know, it's another time for another committee about what we should do to address that in our schools. And hopefully that'll be discussed this year. But what do you think, since you raised that point, what do you think is necessary to address those issues for those children who've endured this pandemic?
That's an excellent question. And I don't want Dr. McDonald to feel left out today. So she is a fellow pediatrician and is very well versed in childhood mental health. So I don't want to steal the floor from you, ma'am.
You're not stealing at all. That as well. I mean, I think we could have entire hearings plus some on that, and worlds of literature to kind of go through that. But obviously what you all are doing with importance of that mental health access immediately in schools, in the community. There's a lot of work going on in pediatricians' offices around identifying those stressors, making early referrals to community-based entities to relieve the stress on parents and home situations, as well as to treat mental health disorders. So, you know, kind of A to Z, looking at your ACEs, which we have lived for the last 2 years for kids, all the way to treatment of conditions. So I think there's a very cross-cutting need there for sure.
I would also add, and I'll acknowledge this may be a hammer and nail situation because I'm a child abuse pediatrician. So I see childhood trauma all the time. And our children as a whole have suffered trauma. And, you know, one of the things that we've learned is home is not always the safest place for some kids. And sometimes they don't eat, and sometimes they're not well supervised, and sometimes they get into things, whether it's substances or firearms or dangerous situations or with dangerous people that they wouldn't have had they been in school. I think one of the things our society has learned more than anything is being in the classroom is paramount to the safety and education of children.
All right, well, thank you for that. So you just referenced, you see those children all the time, and I assume that's in your other employment capacity, part-time, I guess, employment capacity currently, and ongoing. Essentially, I hope you will come to the K-12 Education Committee and share these same views, both of you, because this is going to be an ongoing discussion this year, and I think it's very important. And then just finally, I think you've already spoken to the vaccination and the importance of vaccination, but I'm going to ask you a question. I think it's probably got an obvious answer or maybe more detailed than I'm expecting, but to my colleague's point from Chattanooga, is there anything that would assist our state in shifting from pandemic levels to endemic levels faster?
Then vaccination? Oh, I was waiting on the rest of the question. Sorry.
No, is
Yeah.
vaccination the answer, is what I'm getting at.
Yes, sir. Absolutely. Vaccination is the answer.
Thank you.
Thank you.
Thank you, Mr. Chairman.
Thank you. We're coming up on our time here, and we did have a few more questions. But before we go, I did want you to answer some things that wasn't in your slides as far as COVID-19 in the report that came out. Were you guys able to discern any impact that it has had on the opioid crisis? If you could answer that, and then secondly, even though the opioid naive, I think the on-ramp to addiction, this has obviously had an impact on, but our overdoses have still skyrocketed. Can you address those 2 points?
Right. So the answer is overdoses are worse now. Drug overdoses and drug overdose deaths are worse now than they have been ever. But that's not from prescription drug overdoses. That is from illicit drug overdoses, primarily fentanyl, but also polysubstances, including methamphetamine. And we saw a big spike in the early portion of the pandemic. So like March through June of 2020. And there are a couple of reasons for that. One is with all the interruptions and the lockdowns, people's suppliers and the supply chain of their illicit drugs had to necessarily shift. So they were getting supplies or street drugs from places that they typically didn't get, and the potency and the composition of those were different. And so you saw a big spike. Likewise, that was also the time where money was coming into the pockets of individual Tennesseans in the form of stimulus payments. So they were flush with cash, and combined with the stresses of the pandemic, drove a lot of people out to purchase street drugs that normally don't, or in different quantities. And so overdose deaths really spiked in those first few months of the pandemic. Since that time, they've remained high, and we're actually starting to see some demographic shifts in drug overdoses. But as it pertains to TN Together, they are not, by and large, prescription drugs. They are illicit drugs, essentially fentanyl in most cases.
Thank you, and appreciate you coming and presenting that with us. If I didn't get to you today, if you have any questions, I'm sure they'll be happy to answer your questions, and appreciate it. And with that, we will go back into session, and without any further business, we are adjourned.
Had to give you an opportunity. I didn't.